Good evening, everyone. Welcome to Ismsics Chhattisgarh chapter inauguration. For the people who are outside Chhattisgarh and who are listening to this webinar, just a few glimpses I would like to give is it's, as we all know, it's situated in the heart of India, endowed with rich cultural heritage and attractive natural diversity. The state is full of ancient monuments, rare wildlife species, carved temples, Buddhist sites, waterfalls, caves, rock paintings, hills, plateaus, etc. and etc. So, as it hails to be the heart of India, and I'm proud that I'm sure that in future, Chhattisgarh chapter will be the heart of ISM-SICS society as well. So with this, let's go to the brief introduction about ISM-SICS society, the journey of ISM-SICS society by none other than our executive chairman, Dr. Jagannath Boramani sir.
कि इसमें तो अपना पीपीटी भी तो दिखेगा ना उन लोगों को आवाज अपन यहाँ से बोल देंगे.
Thank you, Dr. Srinivas. I'm going to share my screen. Can you see my screen now?
We can see it, sir.
Yes, sir.
Yes. So, good evening, all of you. ISM-SICS is International Society of Manual Small Incision Cataract Surgeons. This society was launched in 2005 by founder chairman Dr. Amulya Sahu in Mumbai. And now, because of our massive concessional membership drive, we have about 2,000 members as on today in ISM-SICS. These are the glimpses of our first event of launching of ISM-SICS. This was a SICS workshop conducted in Mumbai. Dr. Amulya Sahu was the president of Bombay Ophthalmologist Association that time. So it was launched in 2005, and in the very same year, in 2005, he took our delegation to China for an international event of ISM-SICS. After 2 years, in 2007, we had a big conference in Malaysia, a 3-day conference with live surgeries, wet labs, and deliberations in Tun Hussein On Eye Hospital in Kuala Lumpur. In the next year, the Indonesian annual conference as well as the Singapore annual conference was done under the aegis of ISM-SICS in Indonesia. So again, we had a big ISM-SICS session, live surgeries and wet lab in this conference. In 2009, we had 3 events of ISM-SICS, one in Egypt, Cairo, second was in Sweden, and the third one was in Philippines. In 2013, there was a workshop as well as live surgeries and the surgical camp in South Africa in Dar. In 2015, in Kuala Lumpur, in the APA CRS, ISM-SICS was invited to conduct a wet lab on SICS technique. I was the first editor of ISM-SICS and I published about 7 journals in hard copies. This work was stopped when I stopped being editor, and now very soon we are going to launch again our new journal. We started from 2015 onwards, we started our biennial world conferences. The first biennial world conference was held in Pune in 2015. These conferences are called CCC, that is Comprehensive Cataract Conference. This was in collaboration with Pune Ophthalmological Society. After 2 years, in collaboration with Arvind Eye Care Systems, we did our second world conference in Chennai. This was a grand event attended by 800 delegates, and they had launched their new hospital in Chennai during our conference. In the same conference, we entered into MOU with Help Me See, which is an international organization, international NGO, and who are into development of the virtual simulator for SICS surgery. Then in 2018, in the World Ophthalmological Congress in Barcelona, we conducted wet lab on SICS in Barekar Eye Institute, and in the same conference, our book, Master's Guide of SICS, was launched at the hands of Professor Rafael Barakat. ISM-SICS has partnered with, in ISM-SICS partnership, many CMEs were conducted across India. And then we had given symposia and sessions in various conferences, state conferences, regional conferences, as well as all India conferences in India. This was a major event, again, the Biennial World Conference, CCC 2019, conducted in Kolkata under the able leadership of Dr. Debashish Bhattacharya. This was a grand event attended by more than 1,000 delegates. AIOC has started giving Magic of SICS session to ISM SICS for last 3 years. There are 2 Magic of SICS sessions and we have been given big halls. In last World Conference, which was a virtual one, WOC 2020, though it was not a ISM SICS session, but AIOS gave us a full session only for SICS. In the Kolkata conference, this conference was announced by Dr. Ampon Jangsarzit, November 2020, the midterm world conference in Bangkok, but unfortunately because of the COVID pandemic, now this has to be cancelled. Our next biennial world conference will be in collaboration with PGI Chandigarh. Dr. Jagatram announced this in the Kolkata conference. This was an announcement by Dr. Bonnie Henderson in the Kolkata conference about the 5th biennial world conference in US, that is in 2013. But now it will be in 2015, the 6th biennial world conference in US, and the 2013 conference has been taken over by LV Prasad Eye Institute. We have the presence in almost all states in India, and there is we have been affiliated to AIOS and we have formed chapters outside India, like in US, UK, Mexico, Thailand, and so many countries. Very recently, Russia also is going to launch ISM SICS chapter, and we have the women's wing also. We have future plans like affiliation to International Council of Ophthalmology, and we want to start ISM SICS recognized training centers across the world. If time permits, Dr. Srinath Joshi will talk about this program regarding the PG training program and the ISMS recognized training centers. We'll be starting surgical training soon across the globe in collaboration with Help Me See organization, and Dr. Parishit has recently talked to Help Me See, and they're going to start these programs in Maharashtra very soon. Few days back only, our founder chairman Dr. Amulya Sahu had a talk with the president of US chapter of ISM SICS, Dr. Susan McDonald, and now she wants ISM SICS doctors to have training programs in Tanzania and various African countries. So we'll be calling for the list of the surgeons who are interested to go to these countries. These are the glimpses of the launching event outside India. One was in Egypt, where Dr. Satan Chumata and Dr. Parikshit Gupte had gone. And this is the launching of Bangladesh chapter by Dr. Debashish Bhattacharya. During the pandemic, we have conducted various webinars, and the attendance is almost more than 6,000, 7,000, and we have multiple state and other country chapters also. Very recently, in the past, we have big events like Ophthalmic Women of Substance, the Bangladesh chapter symposium, and the US chapter webinar. So I request everyone to join ISMSS. Those who are not members, you can go to this website, you can take the screenshot, and you can become the member online. Thank you very much.
Thank you, Boramani sir. That was a quick review of how is ISM SICS journey come through, and all thanks to Dr. Sahu sir and to you who have done great work in bringing ISM SICS society, and now it's growing worldwide.
Thanks.
And just for the viewers who are viewing here, Dr. Jagannath Boramani is the first person to start topical ISM SICS in India. Thank you, sir, for that lucid presentation. So we have our founder chairman, the most holy person I know is none other than Dr. Amulya Sahu. So Sahu sir has joined, and I request Dr. Sahu sir to please give a few words of wisdom.
Can you see me?
Yes, sir.
I'm not seeing myself, so
we can see you, sir, very well.
We are able to see you, sir. That's important.
Anyway, you can see me now, so it doesn't matter.
Yes, sir. Please go ahead, sir.
Yeah. See, thank you very much. I'm sorry for the delay because I had a little technical hitch regarding the background downloading. So now Boramani has given you an impression about the journey of ISM SICS. All that I want to say that you feel proud as a global member of this organization. It is going in a very big way. Last 2 days back, I had a talk with almost 45 minutes with Susan McDonald, and she is very enthusiastic about the training programs and other things. And yesterday, I had a talk with the Boris Mal, who is going to be the chairperson in Russia. So I have impressed upon him to start this chapter there, because need of the hour, and everybody has to learn this thing. And what has happened, the world has stopped in the ECC stage. So they have an impression of a messy surgery that time, and suturing and other things, they are not acceptable. Plus, the commercial pressure also has not allowed them to experiment on this line. But I told them, okay, we have come to a level which USA saw that, and they have been so impressed. But Russia has to be, we have to have a webinar with them to get them impressed. Shortly, we are going to have a webinar with the Brazil. They have opened the chapter. Shortly, I will upload their, chapter in the website. So we are going very fast on this track, and in another few days time we will be showing you the training program, and there will be of course changes and other things, but we are launching it soon, and we have a body on that regard. Then Usha Johri will be coordinating all over India, and then any state has got any kind of innovative thinking, other thing, they can go on informing us, and Parikshit will be overlooking all these trainings. So so much for our things, and there are many other things are going to happen, and we are I've asked Jagdish Reddy to and Boramani and all these people will work to have that. We must have a central planning calendar of events, so that every state, their activities should be coordinated now, because every month they must have one program, and every 3 months how many programs, every 6 months how many programs, then annual programs, then out of that filtering the PG student who are bright, bring them an annual competition, then take them to the world conference and honor them, so that talent spotting and talent harnessing will be one of the goals. So those are the things we are going to work. Anybody who wants to have got some idea can share with us. So this much I want to share. A lot of things are happening, and I found that Chhattisgarh also did a very good job in forming that team, and I wish you all the best. Thank you so much.
Thank you, sir, for your kind words of advice and what ISM SICS is going to do in future. I now call upon our president of ISM SICS Society, the most down-to-earth, humble, practical, realistic, and balanced personality I have come across in All India Ophthalmic Society, who is none other than Dr. Debashish Bhattacharya, sir. Debashish, sir.
Srinivas, for this introduction, and my greetings goes to all my seniors, respected seniors, Professor P.K. Mukherjee, and my colleagues and my junior friends in Chhattisgarh for the installation of the Chhattisgarh chapter. It has been always, Chhattisgarh has been kind of a hometown for me, going to Raipur, and we have so many pleasant occasions. I was seeing all my friends there, Dr. Anand Saxena, Dr. Madharia, Dr. Saurabh Luthra, and so many more. And I wish them all the best. You heard from Sahu sir and Dr. Boramani that we are actually running an international society from India on a very important reason, that is the manual small incision cataract surgery. And we are gaining a lot of popularity, and there's a lot of people want to learn, especially the African subcontinent, the Latin America, and also US. We had the US chapter. So the keen interest is for training. So all these things combined together, we use 30 lakh PMMA lenses. So we do 30 lakh SICS every year. So who can be more skilled and experienced? So what Sahu sir said, his vision is very clear that we should be the leaders, and we should take it forwards and share our knowledge with everybody. And in this whole gamut, I think the state chapters form a very crucial role. And I understand with so many leaderships and so many good people in Chhattisgarh, we will definitely come up with a very good ISMICS chapter in Chhattisgarh. Wish you all the best. Thank you very much.
Thank you, Debashis sir, for your kind of support you are showing to ISMSICS Society. Thank you so much. And now I call upon our Vice Chairman of ISMSICS Society, a very sober, pragmatic, and a no-nonsense kind of person I have come across is none other than Dr. Parikshit Gogate. Dada, please.
Thank you for the kind introduction, Srinivas. And I think with the lockdown, all of us have become very sober, and perhaps we may have to stay sober for quite some time to come. No, it is very heartful to see a state like Chhattisgarh, which is a very young state, a very beautiful state, as Srinivas said, also joining the ISMSICS fraternity. And as Devashish sir said, still more than 50% of surgery done in India is manual SICS. And it is the one that serves even the smallest of villages and the remotest of corners. And I am sure that all our members from Chhattisgarh, the office bearers, all the stalwarts and the young enthusiasts will also latch in into this SICS movement and see to it that our patients get the best kind of cataract surgery. Thank you.
Thank you, Dada. Thank you very much. And now comes our Chief National Coordinator, the most energetic, spirited, and high-powered personality of ISMSICS Society, who is none other than Dr. Satanshu Mathur. Bhai Sahab, please go ahead.
Thank you, Srinivas, my brother. First of all, I would like to congratulate Chhattisgarh State Chapter and its all executive members present here. And I believe under the dynamic leadership of Dr. Anand Saxena, my friend Dr. L.C. Madaria, and the vibrant secretary Saurabh Luthra, they will do a great job, and we have full faith in them. And we are thankful that within a short period of time, they have made so many members. And now SICS has present in all the states of India, and 12 international chapters have been made, 2 in the pipeline. So this, in the modern cataract surgery, SICS has made its own place. So we welcome you all in the ISMSICS Society. Thank you very much, Srinivas.
Thank you so much, sir. So with this, now we come to the quick installation of the main Chhattisgarh chapter. I would like to share. I hope you are all able to see my screen. Okay, so we have our incoming chairman of ISMSICS Chhattisgarh chapter, Dr. Anand Saxena sir, who is the director of Aurobindo Eye Hospital, Raipur. Is one of the first VR surgeon of Chhattisgarh, fellow VR from Shankar Nethralaya, Chennai. He is the ex-president of Chhattisgarh Ophthalmic Society, ex-executive member of MEM AIOS, and after all, a wonderful human being. So I asked Sahu sir present a virtual medal to our chairman of ISM Chhattisgarh chapter, and here comes the virtual medal. And I ask you to please hand over the virtual bouquet. Thank you, Sahu sir. May I quickly ask Anand Saxena to please say a few words?
Thank you, sir. Thank you for showing a confidence on me to make me a chairman of this ISMSICS Society of the Chhattisgarh. I hope I can do something good for the society. Thank you once again to everyone.
Thank you, sir. Thank you very much. Rahul, can you please mute everyone? So next we come upon installation of our co-chairman, Dr. Arshad Siddiqui, who's the chairman, scientific committee of Chhattisgarh Ophthalmic Society, director of Siddiqui Eye Hospital, who's an excellent phaco surgeon, fellow of Shankar Nethralaya, Chennai, alumni from Arvind Eye Hospital, Madurai, LDP alumni of AIOS in 2009, president of IMA of Durg in 2018, and at present in practice for the last 27 years. And he has been performing ISMSICS since 1995. So I request Dr. Boramani sir to please present a medal to our incoming co-chairman of ISM SICS Chhattisgarh chapter and also present a virtual bouquet. Thank you, Boramani sir, for that honor. And may I ask Dr. Arshad Siddiqui sir to please unmute himself and please give a quick words of advice.
Good evening, everybody. It's indeed a privilege and honor for me that I have been conferred the task of being co-chairman with Chairman Dr. Anand Saxena sir, and also our President Dr. Madaria and Dr. Saurabh Luthra as our secretary. I've been performing NICS for the last 25 years, and it's indeed now my privilege that we at our state are now going to have an independent chapter, and we hope that we will come up to the expectations of the national chapter. Thank you so much.
Thank you, sir. Thank you very much. Welcome to ISM SICS Society. And quickly, I will now introduce our next president of incoming ISM SICS Society, who is none other than Dr. LC Madaria sir. I'd like to call him as the live wire of ISM SICS Chhattisgarh chapter, the director of Ashirwad Laser and Phaco Eye Hospital, Bilaspur, vice president of ACOIN National Chapter, is the Phaco Fellowship from Shankar Netral at Chennai, Laser Fellowship from RP Center, New Delhi, is also the ex-president of Chhattisgarh Ophthalmic Society and ex-president of IMA Bilaspur. May I request our vice chairman, President Dr. Debashish Bhattacharya sir, to please welcome our incoming president of ISM Chhattisgarh here with the medal, and also request him to please present a virtual bouquet. Thank you, Bhattacharya sir, for that honors. May I request Madaria sir, the live wire, to please say a few words.
Thank you, Srinivas sir, for this nice word. First of all, I thanks all the central body of our SMSICS International Society for opening this beautiful chapter to our Chhattisgarh. As we all know, we tried our best to make the membership drive in our Chhattisgarh, and in a very short time, our dynamic secretary Saurabh Luthra, he has made almost the 60 members in 1 month of time. And under the guidance of Sahu sir and Sudhanshu Mathur sir, we definitely make a beautiful team. And I hope in a coming time, after this pandemic of Corona will finish, we will definitely do a very good CME and all the activity as the central body is expecting. Once again, I thanks the central team to giving a faith on our society. Thank you very much, sir. Thank you.
Thank you so much, Madaria sir. And I hope that the chapter will be, as I said, the heart of ISM SICS India and under your leadership. So next we call upon our incoming vice president. Sorry. Who is Dr. Santosh S. Patel, our incoming Vice President of ISM SICS Chhattisgarh chapter. Dr. Santosh Patel is Associate Professor of Ophthalmology in Jain Medical College, Raipur, and also the well-known VR surgeon. He is Honorable Secretary of Chhattisgarh Ophthalmic Society and Vice President of ACOIN Chhattisgarh chapter. So with this, I request our Vice Chairman, Dr. Parikshit Bogate, to please present our medal, ISM SICS medal, to our incoming Vice President and also present a virtual bouquet. Thank you so much, Dr. Parikshit, for this honors. I quickly request Dr. Santosh Patel, sir, to please say a few words.
Sir, I think he's not able to join. There's some
Okay.
issue. So I
No
would
problem.
just say thanks on his behalf, and I'm sure he would do his best.
Thank you so much. And here comes one of the lively, zestful, strong, and ever-smiling personality and dynamic secretary, who is none other than Dr. Saurabh Luthra. He finished his DO from SRU Chennai and DNB from Agarwal Eye Hospital, the first surgeon to start zepto-cataract surgery in Chhattisgarh, and one of the first few to implant the trifocal, that is the panoptics, and have been the faculty at various state, national, and also an international platforms. So with this, I introduce our dynamic secretary, Dr. Saurabh Luthra, to quickly say a few words, please.
Hi, good evening, everyone. Thank you, Srinivas sir, for such brief introduction and nice introduction, kind words. I hope I can, keep up to this and under the guidance of Sahu sir and all the patrons around. So I request everyone, whosoever has not joined from the Chhattisgarh, we'll make them join and we'll bring up a good job. Thank you.
Thank you so much, Dr. Saurabh. And now I welcome our incoming. So I request Dr. Satanshu Mathur sir to please present our medal to Dr. Saurabh Luthra and induct him as the secretary of ISMSICS Chhattisgarh chapter and also present a virtual bouquet. Thank you very much, Satanshu sir. And now I welcome Dr. Ankur Srivastav, Chairman Scientific Committee of ISMSICS Chhattisgarh chapter, is an associate professor in ophthalmology in AIMS Raipur, formerly head of cataract services at Venu Eye Hospital, Delhi, and he finished his fellowship in orbit oculoplasty and ocular oncology from Arvind Eye Hospital. So I request our chairperson, Dr. Sahu sir, to please induct him with a medal and also with a virtual bouquet.
Sunna,
Thank you so much. May I now request Ankush Srivastav sir to say a few words?
कैसा पेट में दर्द लग रहा है, मरोड़ रहा है, लग रहा है, कैसा लग रहा है? उल्टी जैसा लग रहा है, क्या लग रहा है?
Vijaya ma'am, can you please mute? Dr. Vijaya ma'am, can you please mute?
It's but I think in between there was a quick this note. No problem. I could see smiles on everybody's face. Quickly, Dr. Ankur sir, please go ahead.
Well, thank you for your kind words, and I'm thankful to society for entrusting me with this responsibility. And as Goramani sir has mentioned, for the upcoming general of this society, I will try to keep the flag up high from the Chhattisgarh state. Thank you so much, sir.
Thank you very much. Welcome all the main office bearers, and we also have patron Dr. P.K. Mukherjee sir, advisors Dr. S. Mishra sir, Professor Dr. M.L. Garg, and Dr. Deepshika Agarwal. I think Dr. L.C. Madaria sir will do the rest of the honors to all these and welcome our executive and the scientific committee. With this, I hand over the next task to Dr. L.C. Madaria and Dr. Saurabh Luthra to take over from here. Thank you very much, and we look forward to the wonderful CME after this quick short installation ceremony. Over to Dr. L.C. Madaria, sir, please.
Thank you, sir. Yes, first of all, I thanks the central body. They have installed our Chhattisgarh chapter beautifully in this pandemic area. It is looking like a very live installation. It is not looking like a virtual, because the way they have installed, everybody is enjoying the installation ceremony. I thanks again. A special thanks to Srinivas sir and our president sir and all the your Jagannath sir, then Bhattacharya sir, then Parikshit sir. One thing I will like to comment first before proceeding to introduce our patron. The name of our central body is so wonderful. Sahu sir is Amulya. Amulya means there is जिसका कोई मोल ना हो. वो ऐसी विद्या हम लोगों को सिखा रहे हैं जिसका कोई मूल्य नहीं है, अमूल्य है. He is Amulya Sahu. Another, Dr. Boramani sir. Boramani sir, the way he has explained this our society in international level, he is a Jagannath. Jagannath means Bhagwan, which is present everywhere. So he has made this society to all over world, everywhere. And like that, Parikshit sir. Parikshit sir, he was in our ancient history, he was a king who ran the whole of the India. So definitely, this society is making flag in whole of the India under leadership. And of course, the best coordinator is Dr. Sudhanshu sir, and the best convener is Dr. Srinivas. Srinivas is again, it is a God. It is always present, omnivorous. So with these kind words for our central body, I would like to introduce our state body executives. As Srinivas sir has already introduced our state body, I will just first introduce our patron sir, Dr. P.K. Mukherjee sir. He is our patron. As we all know, Mukherjee sir is in the field of ophthalmology. हम लोग मुखर्जी दादा को कहते हैं गुरुओं के गुरु. In the present status of all the medical college which is existing in Raipur, in Chhattisgarh, उन सबको ऑप्थेल्मोलॉजिस्ट बनाने वाले हमारे गुरु प्रोफेसर पीके मुखर्जी हैं. इसलिए हम इनको सर को गुरुओं के गुरु कहते हैं. सर was the dean of the medical college Raipur. He was the HOD professor of the medical college Raipur. He has written 10 books for the PG in ophthalmology, and he has been given so many awards. G.S. Wagle Award, R.K. Misra Award, and he was the faculty of dean in Ravi Shankar University. So अगर मैं सर के गुणों का बखान करते रहूंगा अवार्ड का, तो मेरा मुंह थक जाएगा, लेकिन उनका लिस्ट नहीं थकेगा. तो with these words, मैं पुनः हमारे गुरुओं के गुरु प्रोफेसर पी.के. मुखर्जी सर को प्रणाम करते हुए, उनका आदर करते हुए, मैं उनको पैटर्न इंट्रोड्यूस कर रहा हूँ. हमारे एडवाइजर हैं डॉक्टर प्रोफेसर मिश्रा सर, डॉक्टर सोमिल मिश्रा सर. Somil Misra sir is also a very wonderful personality. He is the professor and HOD of AIMS Raipur. He has established the ophthalmology in AIMS Raipur. He has 27 years. He has given so many speeches in Maharashtra in 2001, 2014. He received the best teacher award in 2017. He received the International Hero Award of AIOS in 2019. So, under the advice of Professor Somil Misra sir, definitely our society will flourish like anything. Then the next, our advisor is Professor M.L. Garg sir. M.L. Garg sir is a really very thorough gentleman. He is ground to earth person. He is presently professor and HOD of Pandit Jawaharlal Nehru Medical College Raipur. He is master in community ophthalmology. He is authority in ocular trauma. He is a very humble person. He has also given his best wishes to the Chhattisgarh chapter of ISMS SICS. Then the next, our advisor is Deep Shikha Agarwal madam. As we all know, she is the director of MGM Raipur, and she is expert again in community ophthalmology. She has received Asia Award in 2020 in his outstanding work in community ophthalmology. She is an excellent surgeon. So, these are our patron and advisor, and our the other executive persons about whom Dr. Srinivas sir explained. Our dynamic, ever smiling Dr. Anand Saxena, chairman. Then next, then our co-chairperson, Dr. Arshad Siddiqui, to whom Srinivas sir has already explained, is the co-chairperson. Then our next, Dr. Santosh Patel, he is the vice president. Next. Then the most enthusiastic chairman, scientific committee chairman, Dr. Ankur Srivastava. He is also associate professor in AIMS Raipur. and the most dynamic, vibrant our Secretary, Dr. Saurabh Luthra. Because of his sincere effort, only in 1 month, he has made 60 life members in our society. And I hope very soon he will complete the century. With these words, I will request Dr. Saurabh Luthra to introduce our other executive member, Dr. Saurabh Luthra, please.
Sir, thank you for kind words. So it is not 60, we have made 70 members for a small correction.
Oh, sorry.
No, it's
Very
okay,
good,
sir.
very good.
So I'll just share my screen and introduce my executive body here. Yeah, so one second. So I hope my screen is visible. So I'm introducing scientific co-chairman, Dr. Soma Roy. She is practicing in Durg Bhilai. She has her own setup and she's doing a wonderful job. Dr. Reshu Malhotra is assisting her, and both of them would be assisting Dr. Ankush Shrivastava sir. She is a part of medical college and she's one of the finest surgeons I've come across. So in the executive body now, Dr. Harshvardhan Gupta, he's a senior ophthalmologist in Raipur doing refractive and cataract both, and he's doing a commendable job in both the fields of job. Dr. Tamrakar sir, he is a senior eye surgeon from Bemidara. We welcome him as an executive member. And Dr. Sanjay Mehta, he is one of the pioneers in ophthalmology in Bilaspur and one of the most charming personalities. I'm sure once we have a physical conference, we know whom to look forward to. One of the best MCs I have ever come across. Dr. Manish Sharan Srivastava, ये हमारे मुकेश हैं छत्तीसगढ़ के. He's one of the best singers also, and of course one of the bestest community ophthalmologist I've known. Dr. Sanjay Goel, he is a senior eye surgeon from Ambikapur, and now he's joined by his younger son, Dr. Akshay also. They are doing a phenomenal job in Ambikapur. Dr. H.R. Prasad, sir is a senior eye surgeon from Korba, and he is the present president for the state Chhattisgarh State Ophthalmic Society. Welcome, Prasad sir. Dr. Vijay Yuki sir is a senior, again a senior eye surgeon from Chhattisgarh, and he prominently is practicing in Rajnandgaon. Welcome, sir. So now the scientific committee members, Dr. Basant Verma sir, he is one of the first Amsonians from the Chhattisgarh, and he's practicing in Bhilai with his own private setup. Dr. Monica Mailon, she is with the Medical College Bilaspur and is doing a phenomenal job in keratoplasties also. Dr. Kiran Agarwal ma'am, she is with Dr. Anand Saxena sir in Aurobindo Nethralaya. She is an excellent surgeon and a medical retina expert. Dr. Lipi Chakrabarti, she's practicing in Bhilai, Durg again, and she is a glaucoma expert, a fellow from Arvind. Dr. Abhishek Mehra, one of my dearest friends, he is the second generation again in ophthalmology, and he is a pioneer. He's just following his dad's footsteps in doing the community ophthalmology in Chhattisgarh Eye Hospital. Keep up the good work, Abhishek. Dr. Vijaya Sahu ma'am, she is with AIMS Raipur now, and she's also recently finished her surgical retina training from RP Center, Delhi. Welcome you on the scientific committee. My right hand, Dr. Shiv Kumar Nayak, हम MBBS के भी साथी हैं. He is my joint secretary and he is doing a phenomenal job in Raigad. He has a very flourishing practice and he is an excellent surgeon. And again, Dr. KL Demra, he is in Raigad. He is also a second generation ophthalmologist and doing a fairly excellent job in his cataracts and phacos. So we now welcome Dr. Soumya Dulani ma'am. She is the academic and research committee member. She is in Medical College Rajnandgaon. Dr. Meenakshi Masi, she is again a glaucoma expert and practicing in Aurobindo Nethralaya, Raipur. Dr. Rohit Dilavri, he is one of the most bulk surgeons we've come across. He has an excellent hand in SICS and phacos both. Look forward to learning from him and take the guidance. And last but not the least, I am also here. Thank you so much. Over to you, Srinivas sir. Srinivas sir. Okay, I think he must be joining. So with this, I think we would be starting the
Yeah.
CME.
Saurabh,
Sir.
yeah. We have to give the introduction of the speaker.
Yes.
Then the CME will start.
Yes.
Under the guidance of our chairman scientific, Ankur Srivastav.
Correct. So now it is over to Dr. Ankur Srivastav, sir.
Yeah.
Yeah, so thank you, Saurabh, for the introduction. And now we'll move on and conduct the scientific session today. And the first talk is from Dr. Amulya Sahu, sir. Is Dr. Amulya Sahu, sir, there?
Yes, I'm there.
Right, sir. So we'll start with your talk, sir. Your topic is 2 mm manual SICS. Over to you, sir. Sir, you can start.
Yeah, I'm sharing the screen.
Right, sir.
This is not seen. Something is happening, and I think I'm sharing the screen, but I'm not able to see this. What is wrong? Why this thing? Can you remove your things here? Why my share screen? All these things. Can you close down? Dr. Madhare, I'm able to see you. Can you take it off?
Sir, there's a green button at the bottom.
What do you?
Hey, there is a screen. Share your screen.
Yes, sir.
And I have clicked share in screen, but this is coming. My presentations are not coming.
Sir, you have to open your presentation first, and then when the share screen comes, you click on that.
So I'll close down everything.
Yes, sir. You open your presentation, minimize everything.
But now it is I'm come out of these things.
And you open your presentation on the desktop, PPT.
Something new here. Not very. Something wrong is happening.
So meanwhile, sir is getting ready. Can we have the
You can take the other.
Yeah. So
we can.
Meanwhile, sir is getting ready. We'll move on to next speaker, Dr.
Next.
Sir, are you there?
Yeah, I'm there.
Sir, so can we move with your talk? Endo expression of nucleus?
Yes. Can you see my screen?
Yes, sir. I can see your screen. Over to you, sir.
Sure. I'm going to present a technique which is called as endo expression of the nucleus. Generally, most of the times we are using the pulling techniques to pull the nucleus out, either by sandwiching or something. But I think pushing from behind is better than pulling. So this is pushing the nucleus out from the AC from behind. I was doing this technique for almost 5 years, but the term endo expression was coined by our late Dr. Kumar Vikram Singh Dhaliwal, who was one of the strong and young pillar of ISM SICS. Unfortunately, we have lost him. I am using doing the surgery under topical anesthesia and use the AC maintainer also. Because of AC maintenance, many times what happens, if the nucleus is adequate size, you need not push it or pull it also. Only with the fluid pressure, gently it comes out. This is called as auto delivery. Now, many times what happens, I am using the techniques of the nucleus size is big compared to the size of the incisions. My incision size are varying depending upon the pre-existing astigmatism. So if I had to take the nucleus out, because of the AC maintainer, the chamber is fully formed and the side port is always there on the right side. So through the side port, you push a metal instrument like Sinskey hook and try to push out the nucleus. So what happens? The sclera gets stretched and the nucleus sometimes comes out totally, or if there is obstruction, the nucleus gets divided into the scleral tunnel. So you can break the nucleus also into the scleral tunnel, gently rotate the nucleus and take it out. But the pushing of the nucleus from inside out is endo expression of the nucleus. Yeah, this is the second phase, again being pushed out. So you can see the chamber is well formed and the nucleus is being delivered. I'll skip few of the videos and I'll show this video. Now see, this incision is a broad U-shaped incision. This is because of maybe the pre-existing astigmatism is less. So I don't want to induce much astigmatism. But sometimes what happens, the nucleus size is very big compared to the size of the incision. So the nucleus gets stuck into the scleral tunnel. You take the help of the Sinskey hook and push the nucleus out. Now what happens when you push the nucleus out with a metal hook? All the pressure is borne by the walls of the scleral tunnel and not by the endothelium, because the chamber is fully formed and you are pushing the nucleus into the tunnel. So the pressure is borne by the scleral walls and the you are safely away from the endothelium as well as the posterior capsule. Now this must be a case of minimal astigmatism. The cornea must be spherical. So I have taken almost a U-shaped incision here. So this incision will be definitely very small compared to the size of the nucleus. Yes, this is less than 4 mm incision, but the nucleus is again black and quite big one. So take the Sinskey hook, let the nucleus get caught into the scleral tunnel by depressing the posterior wall of the scleral tunnel. The nucleus gets trapped here. You have got the sufficiently wide tunnel inside, even if the incision is small. So the nucleus get stuck there. And take the hook in the right hand and push the nucleus out. So this way the endo expression of the nucleus is done. Many times what happens, because of the fluid pressure of the AC maintainer, the second piece, if it is small, it just jumps out. Just press the posterior of the scleral tunnel and it jumps out like this. So let me stop the video here. So this is a diagrammatic representation. The nucleus is being pushed by the Sinskey hook into the scleral tunnel and you are safely away from the endothelium as well as the posterior capsule. And this is how the endothelium, endo expression of the nucleus works. Because the nucleus is hard for a phaco, because phaco is an ultrasound energy. For that the nucleus might be hard, but it is not hard for a metal hook, which can definitely push the nucleus and either bring it out totally or divide the nucleus into the scleral tunnel. Thank you very much.
Very interesting, sir. And what we could understand from this is that an AC maintainer is mandatory for this technique.
No, it is not mandatory. You can do with the viscofield chamber also.
Okay.
I am using AC maintainer, so I am doing this technique, but it can be done with visco also.
But it is a very nice technique, and you have really small incision size.
Yes.
So that is really good. So can we move on to the next speaker? Amulya Sahu sir, are you ready with your talk?
I'm ready, but can I share it? I've gone into this thing. Can you see it?
Sir, we can see.
Now I have brought this video here. What I'm supposed to do here?
Sir,
click the share screen and click the video then.
Huh?
Click the share screen first.
Share
and then select your video in that window. I think it
should.
Your video is on your.
The video is here. I can see the video.
So when you share screen window, there you click the video again.
Then a share screen is not seen.
And lower part green color. Lowest part green color.
No, it is not there. It was there earlier. Now I am not seeing.
Raman, can you please help him? In front of people can help with that on the phone.
Sir has to move the mic.
Okay. Rahul?
Sir has to move the cursor.
So where I am supposed to click now?
Next to the chat, share screen. A green arrow is there.
It was there earlier. Now I am not seeing it.
Oh.
So
you must be already in the sharing mode and you have to select your video.
Select your video.
That may come on the screen. Let us see.
You see? You can see now. No.
No.
So you take the another speaker. Let me struggle a little.
Dr. Saud sir, Dr. Saud sir, you can send your video to Dr. Boraman. He will play. You can speak.
Okay. No, but I will let the other speaker come and I will find it.
Okay.
So we'll move on to Satanshu Mathur sir.
Yeah.
Welcome.
Ready. Yeah, Ankur. Hello. How are you?
Fine, sir. So the topic for sir is small incision cataract surgery is choice of surgery in difficult cases. Over to you, sir.
Thank you, Ankur. Thank you, Chhattisgarh Society, for this scientific program. I would like to say one thing only, that SICS surgery is not the option of choice nowadays. In past, we used to say SICS is a choice in poor patient in the hard cataracts, but now SICS is the choice of cataract surgery in all types of cataract. This I will like to, Dr. Boramani has developed so many incisions which he is to show us, there you can understand that is the only surgery which can correct pre-operative astigmatism, which no other cataract surgery can do in the world. They are different. For the hard cataract, there are different types of incision, spine incision, straight incision. Straight incision is very good for the beginner, for the students. But now it is this technique prone incision, chevron incision. But nowadays we are doing in the hard cataract inverted incision, where we have a vertical line 2 millimeters away from the limbus, and then we extend it vertically. Straight line, then extend vertically 1 millimeter, and 4 millimeter incision, straight incision, just only 0.5 diopter astigmatism. So this incision is very good. Now, in the hard cataract, we commit capsule axis 6 millimeter. 90% cases is successful. This is a case where we have pre-operative astigmatism of 1.5 diopter and 96 degree. So we have, this was the hard cataract. We have choice of doing phaco with toric lens, but with lot of tension. So we opt for the no tension technique, that SICS and the center of the incision was at 96 degree, and this 1.5 diopter pre-operative astigmatism was covered by this 6 millimeter incision. Post-operative patient has no astigmatism, only 0.25 diopter astigmatism. So that's why I say this is the only technique where you can correct the pre-operative astigmatism also. In the hard cataract, routine things are done as usually we do in every case. Nothing special. Capsule axis is done slightly larger in comparison to phaco. 6 millimeter axis will cover all types of hard cataract. You can remove it. After doing the axis, there are two ways to take out the nucleus, by the hydro procedure or by the 260 hook. So if you do hydro properly, you can take out the nucleus after enlarging the incision. Main thing is that side incision, side pockets. You say we are making side pockets. This is very important. If the incision is small, side pocket should be enough enlarged to help in removing the nucleus through the scleral wound. While injecting fluid, from one side it comes out. Where it comes out, just rotate it and try to bring it down in the chamber after injecting lot of viscoelastic. So we have to protect the endothelium also. By dialer, bring the nucleus into the antechamber. Once it is in the antechamber, there are many techniques to take it out. You can use fish hook, you can have Vervectis, you can use different types of cannula. Once the nucleus is inside the bag, out of the bag, the irrigative actis, once it goes inside, irrigation is off. Once it reaches inside, irrigation starts, and you can see hard cataract has been removed. And by simple putting egg IOL, we have covered the astigmatism. 1.5 diopter astigmatism, but simple PMM lens, that is Devashi was telling you. Instead of wasting money in the toric lens and keeping the tension of operating hard cataract, for which you need high-end machines. And you can, next day you can have a very good cornea with very good vision because the extreme material already has been controlled. Then this is the second technique. Second technique. So by this technique, we can remove the nucleus by 4 millimeter incision, 4.5 millimeter incision. Now Anil Shah, who has developed this technique snare, I am in touch with him, and we are trying to develop a snare like mill loop, where we can divide the nucleus in the bag and make this technique very popular now. So this is snare.
I am not able to share.
So in this technique, we can put the lens by 4 millimeter incision. And one more technique I would like to show. This is again developed by my friend Dr. Thamirnath. Here you can see the incision. I want to show you the incision. We have the linear incision 4.5 millimeter, and then we have extended it vertically. You can see we have extended it vertically on the two sides. So but this gives only estimated of 0.5, 0.75 diameter. The cannula, special cannula is developed which has a base over with the nuclear rest, and you can take it out very easily. This is a cannula. You see, this has a base curvature over which the nuclear rest. This is a curvature over with the nuclear rest, and you can pull it out easily. You can pull it out so easily. This is the hardest cataract removed from 4.5 millimeter linear incision and extension of both sides. This is the hardest cataract. Then you can implant the lens and you can have a good post-operative results. Thank you very much.
Great videos, sir. Really great videos. And you have nicely covered the very basics like importance of internal pockets in small incision cataract surgery and tackling astigmatism. It's always encouraging to see such videos from you. Thank you, sir. Thank you for your presentation. And can we take over Sahu, sir, or shall we proceed?
You can take next speaker. Dr. Sahu will tell himself when he's ready.
Okay. So next I'll move on to my presentation, and that is basics of small incision cataract surgery. Is my screen visible?
Yes, we are visible.
So I have made a very basic presentation, like what are the basics of this small incision cataract surgery. So whenever we are doing our residency training program, our journey of cataract surgery in most of the institutes passes through the stages of extracapsular cataract extraction, moving on to small incision cataract surgery, and finally on to instrumental phacoemulsification. So for a good ECC IOL surgeon, if you have good tissue feeling, if you have good hands-on suture practice, the learning curve for small incision cataract surgery is not big. What I want to convey here is that there are many institutes in India in which the surgeon or the postgraduate resident directly moves from extracapsular extraction, jumps onto the phacoemulsification rather than the graded approach of step-by-step approach. So as you can see in this, there is on the left, there is one technique in which we move from ECC to phaco, and in second from ECC to small incision cataract surgery. And finally, once you have done sufficient number of cases and you are well versed with the tissue settings, now you can move and learn onto the machine settings of phacoemulsification. So in this figure, you can see directly jumping, the person is really at great tension, while a stepwise approach, the person is much more happier. And this is the final result, a graded approach, a stepwise approach moving on from ECC to SICS to phacoemulsification always saves your life, especially when you have smaller complications like runaway rhexis. In such situations, you can always convert it and make a proper tunnel rather than just directly moving on to extracapsular cataract extraction and putting sutures. For example, if you are doing a multifocal IOL or a toric IOL and you have planned phacoemulsification surgery and don't know SICS, and if something goes wrong, then you directly have to convert it to ECC, and then you will be in trouble. So what I want to convey is that being in academic institute, it's always better to have a stepwise approach, moving gradually from extracapsular to small incision cataract surgery and finally the phacoemulsification. So as a resident, what should be the ideal case for a small incision cataract surgery as a beginner once you've started? The first and the foremost thing is clarity, that is good cornea. If you want your patient to see, have a nice vision and to see beautifully next day, then it is really very important that you should be able to see the NTS-MS structures while you are operating. Of course, we do take difficult cases when we are more proficient, but as a beginner, a good cornea through which you can see the NTS-MS structure is very, very important. Secondly, as Tanshu sir has said, a well-dilated pupil. There are many studies that less than 6 mm pupillary diameter increases the surgical complications by more than 50%. And this is more so needed when you are doing an small incision cataract surgery. And adequate pupillary dilatation is definitely required. The third is the grade of cataract, that what grade are you using. And when I was a resident, I always prefer that I can be allotted a white mature cataract when I'm starting my small incision cataract surgery, because it is easier to handle and of course not much is left for irrigation and aspiration. So choose your case widely. These are the so-called things which produces nightmares for the beginners. So I have labeled it as so-called contraindications for the beginners. Things like pseudo exfoliation, the chances of zonal dialysis and Rex's runaway are more. Endothelial dystrophy, small pupil, as we have talked of. The difficult situations like intumescent cataract, Morganian cataract, and subluxated cataract. So what is new when you move on to small incision cataract surgery? We all have practiced on simulators. We have learned about putting sutures. We have the tissue feeling while doing ECC. But when you shift to SICS, it is definitely technically more demanding for you. And the first thing which comes in our way is construction of a proper tunnel. The other things which we'll take one by one is capsular access, hydrotraction, flipping the nucleus, removal. But the first challenge is construction of proper tunnel. So as we can see in extracapsular cataract extraction, it is a simple uniplanar incision. But in small incision cataract surgery, it consists of a triplanar incision, which is having three components, that is external scleral incision, then it moves up into a sclerocornea, and finally the internal wound entry, that is the corneal incision. So as compared to the single plane of ECC, we can see that manual SICS, it's triplanar as is shown here. So this principle is also utilized by many surgeons when they are transforming into clear corneal phacoemulsification. So this gives you a very beautiful self-sealing wound. Now, the second thing which we should learn at this stage, and which poses a challenge to most of the surgeons, and it has been made mandatory by most of the institutes, that when you are transforming from ECC to a small incision cataract surgery, better to learn capsular access at this stage only. Leave canopial capsulotomy for ECC, and better to learn capsular access at this stage only. And definitely it helps you when you further goes into your transformation in phacoemulsification. So this is the basic difference. While in phaco, the ideal size of rexes which we speak is about 5.5 mm. You need to have a slightly bigger capsular opening when you're doing SICS, so that for the beginner especially, you can easily prolapse and flip the nucleus into the anterior chamber. Do a good hydrodissection so that the nucleus is free. Of course, there are contraindications to hydrodissection, which is beyond the scope of this talk. So do a proper hydrodissection, make the nucleus free, and then next crucial step, once you have learned all this, is flipping the nucleus into the anterior chamber. In ECC, this step was not there, and pressure counterpressure technique and many techniques will remove the nucleus. But flipping the nucleus through a Sins cube or through the instrument of choice is a very, very crucial step. You are actually being very close to PC in this step. So I've removed the video here. So finally, once you have flipped it, then whatever is the technique, it could be visco expression, as we have seen, endo expression by Boramani sir, or it could be hydro expression using irrigating vectors, depends on the choice and comfort level of surgeon. You can just express out the nucleus and finally put an IOL. So this is what I want to convey from today's talk, is that a proper stepwise approach to learning is really very important. And as we have seen in videos, even the difficult of cases can easily be handled through small incision cataract surgery. And finally, hydrate your side port and test for patency of tunnel. And one more message I want, there should not be an ego. If it needs a suture, put a suture. It doesn't take anything. Thank you all for your kind attention.
Thank you and good. Your approach for the PG students and learners is really very good. It shows you are a teacher already. So we'll utilize your services in the training. Dr. Parikshit must be here. He will pinpoint you for the training of the next generation.
Thank you, sir.
Dr. Boramani, sir, Dr. Sahu sir is not picking phone. Is ready?
I don't know.
Anshu sir, can I start?
Yes,
Yes,
yes.
you can start, Parikshit.
I can start. Okay, I will share my screen.
Yeah. Parikshit, you remove your background. Your face is not coming.
Yeah,
I know, no, I will share the screen. That is why I do it through the mobile.
Okay, you share the screen.
Sir, can you see my screen?
Not started till now. Yes, started. Yes.
Yep.
Yeah.
Yeah. Last slide, I think.
You are first. Start from first.
Well, at the outset, I would like to thank the Chhattisgarh chapter for giving me this opportunity. We have to understand that cataract is today a refractive surgery. It's not just for restoring vision, but for giving perfect vision. We know that the use of intraocular lenses, I remember when I was a resident, the most common refraction that we gave was +10 plus 1.5 into 180 degrees. So the use of IOLs did away with the large sphere. The use of SICS or phaco did away with the cylinder. And today multifocals are doing away with the reading addition. So if today phaco is like the king of the cataract surgery, even manual small incision surgery is a great surgery in its own right. So earlier SICS was considered a poor cousin of phaco. But we did a meta-analysis in which we compared both the techniques, with phaco giving better unaided vision due to lesser astigmatism. And everything between phaco and SICS is the same. So these are the 11 studies which have compared phaco with SICS. So there is no difference at 618 or 660, but there is a small difference at 6.9. This difference at 6.9 cutoff is because the astigmatism is less in phaco. There is no difference either for endothelial cell loss or intra-op or post-op complications. We know SICS is safer for beginner surgeons, but then the astigmatism is less in phaco. So this is what the meta-analysis showed. So if you can see all of them, the astigmatism is less in phaco. But because there is less astigmatism in phacoemulsification, the distance vision is very good, 6.6, but the near vision is not good, as we found from a study from Biraj. And unaided near vision is important even for illiterate patients, rural communities, for needlework, cooking, cleaning, looking at mobiles, and differentiating currency. So while astigmatism is an issue differentiating the two techniques for us doctors, it does not seem to have much impact on functional vision. We know SICS takes less time. We know SICS is much cheaper. So each has its own merits and demerits. And today, if we want to give our patients good unaided distant and near vision also, then manual small incision cataract surgery is definitely a good alternative to phacoemulsification. So the near vision is a differentiator because SICS gives better unaided near vision as compared to phacoemulsification, which is also very important. So I would like to thank the Chhattisgarh chapter and its scientific committee for giving me this opportunity. Thank you, sir.
Dr. Sahu sir, are you ready? Parikshit?
Yes, sir.
Time when Dr. Sahu sir is ready, can you elaborate for the benefit of the audience how the SICS will improve the near vision better than phaco?
Because of cylinder.
Yeah, Prashit.
So, because in SICS there is a small amount of astigmatism that is there, it is like the Stroom's conoid. So the depth of focus that the patient gets is more with manual small incision surgery. So this is what is used in the smart SICS surgery also, that because the corneal curvature changes, the patient also gets some good unaided near vision, which is not possible in phaco. I think Sahu sir has come, sir.
We can start with him. Dr. Ankur, you can invite Dr. Sahu, sir.
Dr. Sahu, sir, please unmute yourself.
Hello.
Yes, sir.
Can you hear me?
Yeah, we can hear you, sir.
We can hear you, sir.
Some or other, I am not able to share my video. So I'm sorry for that. My knowledge.
But you can speak. You can, without video, can speak about your presentation, sir.
Okay, 2 millimeter MSICS is something you have to all up to work for that, and it is the ultimate, and with thousands of operations, and I can tell you with lot of assurance that once you master this, there is no need for a phaco, because ultimately the aim to phaco is a small incision, and you, instead of cornea, you are doing an incision at the sclera, which is a much stable ground. And with that, if you are doing all the multifocal toric and IPCL, which I am doing, then what is the need of a phaco? But phaco you can keep for a fashion and just to have an say that you are a complete cataract surgeon. Otherwise, 2 millimeter is the something where we all must move. And besides other technique which Boramani is forwarding, and now we are going for a robotic SICS. So lot of things are happening, and I'm very satisfied with 2 millimeter. Thank you very much.
Thank you, Sahu, sir. And I, to the Chhattisgarh or the public from the Chhattisgarh doctors and other, Dr. Sahu, sir, by motivated by your presentation, I have started doing 3 millimeter with vertical extension 1 meter. And intertunnel fracture, we are able to remove almost all types of cataract.
Yeah.
It is not difficult to do 2 millimeter. We have come to 3 millimeter, then we will come to 2 millimeter also. You have been a very motivating force, sir, for us to bring the size of the incision to a level of 2 millimeter only.
Yeah. So result is so encouraging. I think all the senior surgeon must now focus on reducing the size of the incision.
Next presentation, sir, I will present the video where we have done it not by 2 by 3 millimeters, sir.
Right.
That's very good.
2 millimeter will be all around. Now, once you give a vertical cut on either side.
Yeah, we are giving this, sir.
Though if you are giving the vertical cut, 2 millimeter is possible because your pocket will be there available.
Yeah.
So now, if you are only giving an incision, and it will be difficult. But if you give a vertical cut on the either side, then you are getting a lot of space inside. So that way you can reduce to 2 millimeter.
Dr. Boramani, sir.
Yeah.
Your any opinion, assertions?
Yeah, I just want to say a few things, because SICS is always compared with the phaco, but a standard SICS with a straight incision or prawn incision is compared with the phaco. And whatever the publications are there, like Dr. Parikshit said, because he is talking about the meta-analysis, which is as per the published literature, the induced astigmatism is more in SICS than phaco because the incision is more. But if you have got the customization of the incision, like I am doing the customization of the incision, depending upon the pre-existing astigmatism, I customize the incision. So, can I stop here? He's showing the video. Sir. We'll discuss afterwards.
Saurabh has uploaded or somebody has uploaded?
Yeah, we can see now. You speak.
I am putting it from YouTube for Sahu, sir. He can talk about
it.
Yes,
great job. Saurabh, great job. So that's why I told you a dynamic person.
Make it a full screen.
Okay.
Yeah.
I'll restart it.
Sure.
Restart?
Yeah. He can speak now.
So this is my marker which I have designed, and now I take the incision on the steep axis, okay, and I separate the conjunctiva and tenon separately, because then while I opposing also I put the tenons first, and then over that I close the conjunctiva, and next day you cannot see where the operation has been done. See these vertical cuts, Satanshu, if you are looking.
Yes, sir.
So yeah, these vertical cuts will easily you can get into 2 millimeter.
That's true, sir. That's true. This is very helping.
Uh-huh.
Side pockets and vertical cuts.
So you always try to stick to the steep axis and have your data properly documented, so that that will give you, and question it when we are not getting 6 and 6. I have got yesterday this multifocal patient came to me after 1 month, and 6 and 6 I will share that thing. K reading is absolutely new.
Sir, please unmute yourself.
Yeah. Can you hear me?
Yes, sir. We can.
Now we hear you.
Yeah. See where I'm holding the, most of the time I've seen in the beginners, they hold the tip of the incision. Don't do that. And this is a modified dialer. This is a modified vectis. The vectis has got a something, it has got a sharp edge. Not very sharp, but there is a sharp edge, and there is a hanging front. And so, and bringing out the lens is very easy. There is no problem at all. And I give 2 side ports, and this is also a modified Simcoe cannula. It is a 24 gauge Simcoe cannula, because I don't have to extend the side pocket, otherwise there will be iris prolapse, or then you have to force it through the side pocket where the descent separation can happen. The mild polishing is there, and now I can put the lens directly. If I have given a vertical cords, there is no need for a injector. Though if I am not given a vertical cord, then I can use an injector, or whenever I feel like use the injector, or I can use the directly put the, so that. So all the seniors who are seeing it, who have done thousands of operations, they have to now come to this. See, I am not saying that we should not do a big incision. We have to be very open-minded. If it is a very, very hard cataract and rubbery cataract, don't hesitate to give a big incision, because as you see, Boramani is wound modulation that you have to learn. With even a very big cataract, you can give a astigmatic neutral thing. So we have a lot of variety with us. Each technique has to be mastered. And next day when you see the cornea, it's a clear cornea, and try to have a photograph of the clear cornea, so that you are satisfied that I have not created any problems, and I have got the Conan, this thing endothelial counts. I have seen very hardly any reduction, but the beginners has to be little watchful, because there is a chance of compromising endothelia. So
right. Very nice, sir. Very nice.
Yeah. Can I come in now?
Yeah. In many cases, sir, still we are doing phaco since last 15 to 20 years, but still we find in many times when we find a black cataract, almost black cataract, and the age is a patient age is 75, 80. In that cases, we definitely perform this SICS, because the cornea is almost compromised at this stage. So in all the difficult cases, still, and as the Sahu sir has very beautifully given this idea of 2 millimeter, 2 mm also. So definitely this is a very good technique still. So thank you very much, sir. Thank you very much.
So
Now over to Dr. Ankur.
you try now to reduce the size of the incision and see what is coming out.
Sir.
I think Boramani sir has something to speak.
Yeah, I have to say a few things. Now, I was talking about the newer developments in SICS. So all of you know about the basic SICS, but now we are talking about the advanced SICS.
Right.
So these are the major developments, but so far without publications in the peer-reviewed journal. One publication from Dr. Rajiv Raut has already gone, submitted to Indian Journal of Ophthalmology. But very soon the publications also will come. But without the publications also, there are so many practical, because today I didn't talk on my favorite subject, that is the customization of the incisions, because always I talk on that subject. So today I took the endo expression of the nucleus. But if someone asks me, what is your induced astigmatism? Everyone will say, Mera to 0.3 hai, mera 0.5 hai. But I say this question is very irrelevant to me, because if a spherical cornea comes to me, you have seen that U-shaped incision. It doesn't induce any astigmatism, because say a 6 mm prawn will induce say about 0.75. If we make it more curved, it may go down to 0.5. If we make it more curved, it will be 0.4, 0.3. Then if it is a U-shaped, it has to be very less or almost no astigmatism. I can show you so many of my patients where predictably I can show you the pre-op and post-op topographies where there is no change in the astigmatism. So I implant premium lenses with more and more confidence, because I know how much astigmatism I am going to neutralize. So I'll give 2 examples. A case of multifocal IOL comes to me without any astigmatism. So even if I am an SICS surgeon, I am not worried about the induction of the astigmatism, because I got a very good control on my incision. I take a U-shaped superior temporal incision and I don't induce anything. But I'll tell you, very recently, before the pandemic, a doctor patient came to me. Patient was a practicing doctor, a specialist, and his astigmatism was 1.75 diopters. And he was very keen for a multifocal IOL. Any surgeon will definitely advise a toric IOL for this case. Now, in this case, I operated him without toric IOL, but I put a multifocal lens. His steep axis was 165 meridian on left hand. So I took a superior nasal on 165. The incision was a very straight one, and a large incision, 7 millimeter straight incision, because I wanted to neutralize that. And postoperatively, he is enjoying a good vision. His refraction is plano, perfect plano. Astigmatism on topography is 0.15 only. So 1.75 is reduced to 0.15. So depending upon the pre-existing astigmatism, we can modify the shape, and these incisions behave differently in different quadrants. Superiorly, they are strongly neutralizing. Temporally, they are weakly neutralizing. That you have to keep in mind. So we keep getting patients with different types of astigmatism in different meridians. So every time, how can only a 2.2 mm clear corneal incision will be answer to that? So even I have seen many eminent phaco surgeons only 0.5, 0.75 astigmatism, they advise a toric IOL. I also do toric IOL for very high astigmatism, especially if the steep axis is temporal one. But otherwise, for up to 0.1, 1.5, I do without toric IOL. I charge more to the patient, and I sell this as a premium surgery without a premium IOL. So you put a non-toric lens, but you charge more for the. So instead of paying to the company, the patient pays you. Another example is there are cases wherein patients astigmatism is 3.5, 3.75 diopters, and especially if this is a steep meridian vertical one. I take a 7.5 mm straight incision, go very close to the cornea, and this way I neutralize, and these patients come down to 0.5 or 0.25. So this way you can play with the astigmatism. So if you start doing this way, and if you have got a confidence, then you always feel that why should you do phaco? Because if someone forces me to do a phaco, I always carry a feeling that I am doing injustice to the patient, because I got a technique which is superior and better controlling the astigmatism. If someone wants a video on this, there is a video on YouTube. If you just put my name Boramani, you can find that video. It is a 5-year-old video. Another newer development in SICS is a smart incision. Dr. Rajiv Raut from Pune started smart incision. He was using a handheld keratoscope, and this was giving a multifocality to the patient with a monofocal lens. But he developed a software 2 years back, and now it is a software guided smart SICS. And we are using, even I am also trying this statement. He has given the software to us also. About 15 surgeons in India have started using this, and patients are developing good multifocality, because this multifocality is without any glares or halos. And now very recently, I don't know whether we should disclose this or not, but now he is going to start the robotic smart SICS. And mostly in our Chandigarh conference, there will be a live demonstration of robotic smart SICS. Third one is Dr. Sahu's 2mm SICS. 2mm SICS is a wonderful technique. And all these presentations were done very recently in our US chapter webinar. And all the top-notch phaco surgeons like Susan McDonald, Dr. Bonnie Henderson, all of them are so impressed. Dr. Susan kept seeing the magical when Dr. Sahu was presenting. They have asked for our videos and they want to present in the US all these superior techniques. So if we do start learning the advanced technique, it's a wonderful and superior technique. I can proudly say that last 7 years I have stopped using phaco. Phaco machine is there with me, but I use it on Dashara day for puja and once in a blue moon when I have to do vitrectomy. I use the phaco machine, but otherwise I don't do phaco. Thank you very much.
Nice.
Thank you, Dr. Bonamas.
Excellent.
As I showed in my first video, I showed it 1.5 millimeter extremities was controlled. 1.5 data speed is controlled by simple 6 millimeter incision in the vertical position at 96 degree, 1 minute away from the limbus. So this is the only technique, that's why I told you, which can control the preoperative extremity. We cannot control in phaco without rolling IOL. Thank you, Dr. Yes, Dr. Madan.
So instead of SICS, I called it CICS, KICS, Customized Incision Cataract Surgery.
That's true. That's
and I don't use the term surgically induced astigmatism because it is an unwanted pregnancy. I use the term surgically
corrected.
Surgically corrected astigmatism because it is a planned child, SCA. Thank you.
Sir,
all the nomenclature are going to change very soon.
Boramani sir.
Yes.
Very nicely you have explained how to correct the astigmatism in SICS.
Correct.
So, sir, a good publication is required, sir, by you.
Yes, absolutely, absolutely.
So that will help all the persons who are doing it.
Yeah.
And definitely it is a very, very interesting thing.
This video is there on the YouTube, but I'm working on the publication also because unless you publish in a peer-reviewed journal, the world will not listen to you.
Yeah. Thank you, sir. Thank you. Thank you very much.
One more thing I want to tell that, can you hear me?
Yes, sir.
Yes, sir.
See, it will not be any more 6 millimeter. We will not call it a small incision cataract surgery. We will call it a scleral incision cataract surgery. And only when you are doing 2 or 3 millimeter, it will be a small incision cataract surgery.
Right.
This nomenclature has to change. Otherwise, you will be hypocrites. Anybody can question you. You are doing a 6 millimeter. How you call it is a small incision?
Yes, exactly.
So we have to now change that thing. It's a scleral incision. We are scleral surgeon, and they are corneal surgeon. Phaco is cornea. SICS is sclera. Okay.
Right, sir.
And we are now also doing limbal. Today I did a limbal incision cataract surgery. The video I am showing. That is also a good area. But that incision has to be extended up to, at least I did it with a 5 millimeter. But can you reduce it to size? That I have to see. It's a good surgery. So without separating the conjunctiva, so I did this SICS, but I have to keep it because it was my second case. So I don't want to reduce the size unless I go little more, and then I'll start reducing my size and see. Thank you.
It's really interesting to listen all this, sir. And with the advancement in field of small incision cataract surgery going, few years back, people were not questioning putting foldable IOL in SICS, and now just people are putting multifocal IOLs. It's really
multiple. Yes. PPF, IPCL, and everything we are doing.
You can put all the types of lenses, including PMMA, in SICS. This is the advantage. You cannot put PMMA in phaco surgery. And to describe the importance of SICS is only one question. I'll ask you one question. You must have seen various presentations. When to convert to SICS? You're doing a phaco, some tricky situation comes, and always the surgeon said, yeah, I have to convert now to SICS. Tell me a single situation, you have planned SICS surgery, and you decide, oh, I have to convert to phaco now. This is going to be difficult. Let me convert to phaco. Has it happened any time?
Is it SICS to phaco or phaco to SICS?
SICS to phaco. Is there any situation? No. So this means that SICS can cover all 100 types of cataract, 100% cataract.
The best answer. And that is what I covered in my talk, that
correct.
You just jump from ECC to phaco. Always.
Yes. Yeah.
It is mandated to learn.
As a SICS surgeon, you are an artist.
you are an artist. That is,
You are not bound by parameters.
you are not bound by machines and parameters. It's more of your skill rather than machine part.
Yeah, so you take pride that as I'm an artist, I'm
Yes.
a performer, par excellence.
These advances you have shown, sir, it's really
Ankur, now time has come when we proudly say we are SICS surgeon. I remember
Yes, yes.
15 years back when I go to the SICS meeting in the AIS, there was only my talk in the SICS, one or two other person talk. Now we have full sessions, not 1 hour, 2 hour, 2 hour session, not one session, 2 session in AIS conferences. So that shows the importance of SICS, the mind of the people who are accepting it as a good surgery.
right, definitely, sir. So
Right.
with this, we'll come to the end of this scientific session, and we'll definitely like to have one physical CME once the COVID situation is over, under the leadership of Pandaria sir. And it will be great to listen from you all speakers. And with this, now hand over to Dr. Saurabh Luthra to give his vote of thanks. Over to you, Saurabh.
Yeah, thank you, Ankur sir. So before word of thanks, I just want to share something which has recently come up. Is my screen there?
Yes.
Yeah. So
Yes, we can hear it, Saurabh sir.
Before the thanks, I would just like to add on to this phenocane assisted cataract surgery. So either it is an SICS or a phaco. We all know that we need a good mydriasis to overcome a uneventful cataract surgery. And we all know the problems we face during an intraoperative meiosis, whether either it is pre cataract extraction or during an implantation, we want a good, fairly dilated pupil. So importance of stable mydriasis is something which we all want to be there throughout the surgery. In the 2013 European Observatory Cataract Surgery Survey, the importance of stable mydriasis during surgery was rated as 9 on a 10-point scale, which itself says that how important this is. So is topical mydriasis the solution? Yes, we are fairly onto this and we've been practicing with the help of this. But yeah, it takes time. There can be sometimes the limited bioavailability. At times we don't even know there is a non-negligible systemic absorption, and inconsistent mydriasis at times also has to be faced. So is there an alternative? Yes. We have something called the intracameral injections, which has been recently launched by the Entod people, and I have recently received my share of samples, and I've used it in 2 cases. I don't have the video, but the promptness is just unbelievable. It is happening in seconds. The mydriasis is stable. It improves the intraoperative conditions during crucial steps such as intraocular lens implantation. It is very safe and effective alternative with less risk of systemic exposure. And it showed that the dilatation happened in 28.6 seconds compared to the 20 minutes for a topical drop to act, and it was the mean pupil diameter was seen to be around 7 millimeter, which is an excellent thing for a cataract surgeon. So they have proudly introduced phenocane, and we welcome this product. I'm sure because of the help of the composition, the tropicamide and phenylephrine is something we already have, but the lidocaine is the key player here. It reduces. It will be a game changer in the topical phacos and topical SICS. The dosage and administration is slowly inject 0.2 ml of this phenocane plus via intracameral route. Directly, you have to load this in a syringe and then just see the magic. Thank you so much. So with this, I will just stop my screen.
Corroborate
Sir? Okay.
It gives excellent results.
Yeah, sir. I know.
Saurabh, this drug has one more benefit except in the topical, it is anesthetic effect also.
Yes, true, sir.
And one most benefit which I found in my cases recently, in lens-induced glaucoma, if we dilate the people, patient is tension raised, and we have to give the mannitol, we have to give the acetazolamide. But now I will stop dilating the lens-induced glaucoma cases. We dilate on the table only.
Even the hypermature cataract.
Yeah, hypermature, we dilate on the table only.
Yes, sir.
But they cause raise of tension, we avoid dilating in advance.
Yes, sir.
There is one more benefit. You can note down this.
Yeah. So with this, we come to the end of this session. I would want to pass my gratitude to all the office bearers, especially Dr. Devashish sir, Dr. Amulya Sahu sir, Dr. Buramani sir, Dr. Gugate sir, Dr. Sudhanshu Matu sir, and my dear friend Dr. Srinivas Joshi sir, and also to all my dear state colleagues and executive body members. We need to take this figure up and above and bring up this magical surgery, the art of the surgery, to a next level. Also thanking the Antod people for the organizing it flawlessly, especially especially Mr. Raman, Rahul, Rohit. Without you, it would not have been possible. So with this, we call this an end. Thank you so much. Have a pleasant evening, all of you.
Thank
Have
you.
a fantastic weekend and stay safe.
Yeah, thank you for the
Thank
wonderful
you.
webinar.
Good night.
Thank you.
Lovely
Good night.
webinar.
Good night, everyone. Yeah.
Good night.
Dr.
Good night.
Madaria,
Good night, everyone.
Dr. Madaria, Saurabh, really thanks to you for keeping my words. You have done a
Yeah.
great job on
Great job.
Sir,
Great job.
it is our
on my
pleasure.
one request. You have done a great job.
Thank
All
you.
the best
Thank
to
you.
Chhattisgarh chapter.
Thank you.
Thank you, Puramani sir.
Thank you, Saurabh. Thank you. Very nice.
जाते जाते एक छोटा सा संजय मेहता सर की तरफ से एक कुछ छोटा सा हो जाए हमारे
हाँ
फेवरेट
बिल्कुल 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 संजय
महफिल बढ़ रहा है अभी। यस 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 तीन गलतियां हो गई छत्तीसगढ़ वालों से प्यार हो गया आपसे हो गया
Can we
और
go offline?
बेशुमार हो गया
Offline जाओ.
Can we go offline?
Stop the webcast.
Wait for 1 minute.
Wait for 1 minute.